over to you.
Okay, great. I'm so sorry. Okay, so thank you so much for inviting me to speak today. My name is Carlotta. I'm one of the consultants in maternal medicine, obstetrics and gynecology at Croydon. I will be talking to you about the thromboembolic risk and assessment of risk in pregnancy and afterwards, and also management of thromboembolic disease in pregnancy and after pregnancy. So just briefly, the contents of my presentation. I have one slide on Embrace, which just tells us how important it is to still talk about thromboembolic disease. Then I will go on to risk assessment. We will talk a little bit about risk factors, about women who had previous VTEs, but women who have thrombophilias. And I have a couple of case studies just to make us think about what the implications are in real life of assessing risk and telling women that they need to start to do an injection every day. And then just a little bit about management of thromboembolic disease in pregnancy and a few other important factors that we need to consider. If any questions arise, please stop me, but I will have some time for questions afterwards. So as I said, I have a slide which you have probably seen before. A lot of people use them in their presentations, but it's just so important. So blood clots are still in the top 3 causes of maternal death. And it's just, we want to do everything we can for this not to happen. And this is why risk assessment, proper risk assessment is so important. So moving on to risk assessment, when do we do it? I've put here pre-pregnancy as well as at booking. In terms of pre-pregnancy, I'm thinking about women who, for example, have a blood clotting disorder, or women who have had a clot in the past, or women who have a family history of blood clots. So these women will be at higher risk, and some of them will need low molecular weight heparin from the start of the pregnancy, so maybe before we even get to meet them. And that's why it's so important for us and for other healthcare professionals to discuss VTE risk assessment and their sort of need for low molecular weight heparin throughout the pregnancy. The assessment then it's repeated at every hospital admission and at every change in circumstances. This just makes me think of a woman who I met this week who she had a BMI of something like 36, 37. She was 39 and her twin sister was pregnant at the same time as her, but had just had a clot. So she came to me asking, my sister just had a clot. Do I need to do anything about that? Yes, that completely changed her risk factors. She had 2 risk factors initially, her age and her BMI, but then with a family history of a clot, which was driven by estrogen, so in pregnancy, she needed low molecular weight heparin. So it just makes you think about what women tell you and how their risk changes throughout the pregnancy. And then we repeat the risk assessment when they come in labor and after. So the type of delivery that they have may put them at lower or higher risk depending on the other risk factors. So what are these risk factors? This slide is from the guideline, the RCOG guideline. You'll be familiar with this slide or something very similar. So every hospital has adapted this slide onto their VTE guidelines. Why everyone has changed it, I don't know. But they're all very similar. And the risk factors are essentially these that are on this RCOG slide. So we have very high. So on the left, you have antenatal, and on the right, you have postnatal. On the top, you have people who are very high risk of clots. So people who will require thromboprophylaxis from the start of the pregnancy, such as women who have previously had blood clots, which are not related to major surgery. Going down, you have intermediate risk, so women who you may want to consider low molecular weight heparin during their pregnancy. So women who have come into hospital and are pregnant, even if they don't have any other risk factors. But it also depends on what they come into hospital with. So have they come with hyperemesis? Have they come with sepsis? That puts them at higher risk of clots. Women with thrombophilias, but no BTs in the past. Women with other comorbidities, with increasing age, maternal age, we have increasing women with comorbidities, things like heart disease, things like cancer. So we need to be aware that these will put them at higher risk. And then the blue one, the blue box highlights the risk factors. So 4 or more risk factors, you put them in the first trimester on thromboprophylaxis. 3 or more from 28 weeks, and 2 and less than 2, you consider it only if they're admitted into hospital. With lower risk women, you try and mobilize them, you make sure that they avoid dehydration. I'm not going to go through every single risk factor. You're probably familiar with most of them, things like obesity, age, parity, smoker, but you can access the slide yourself on the RCOG, and probably you can access my slides afterwards. I'll make sure that they send them to you. So moving on, so as I said, who should receive thromboprophylaxis and when? So as we talked about, 4 or more risk factors, you give them throughout the antenatal periods and for 6 weeks postnatally. 3 or more from 28 weeks, 2 or more from either 10 days or 6 weeks postnatally. And obviously any woman who's admitted, you speak about starting low molecular weight heparin. So just, I will highlight it again afterwards, but this is a very long time that a woman has to inject herself with a needle. And the vast majority of women don't like needles. And that's why I think it's really important to stress the importance with women of thromboprophylaxis. Really often when I start a woman, I speak about the EMBRACE report, and I talk about the fact that blood clots are still one of the highest risk factors for mortality in pregnancy. Just so that, not to scare them, but I think it's really important for them to understand it, because we give them so many medications and they're much more likely to take something like, I don't know, omeprazole that isn't, you know, yes, it can help them, but it's not that important, than something like Clexane or any other thromboprophylaxis that you use in your hospital. So it's really important that that the women understand why it's so important for them to take it. So I'm just going to talk about, first of all, women with previous blood clots, and then about women with thrombophilias. These are 2 groups that are highlighted in the RCOG guidelines, and 2 groups also that we just all get a bit confused. Should they start it? When should they start it? So each woman is different. You will need to risk assess each one of these women and think about why she had a blood clot. So some women had a blood clot because they've had major surgery, and that was the only reason. It was treated for 3 months, she stopped it, and then she has no other risk factor. Some women have blood clots because they have thrombophilias. Some women have blood clots when they are on the combined oral contraceptive pill or when they're pregnant. These women will need thromboprophylaxis throughout their pregnancy. But in all of these women, they will need some sort of thromboprophylaxis at some point in their pregnancy. So let's have a look at in a little bit more detail. So if the blood clot was unprovoked or related to estrogen, so if she was on the oral contraceptive pill or she was pregnant, you need thromboprophylaxis throughout the antenatal period. If it was provoked by major surgery and she is young, skinny, active, no other risk factors, doesn't smoke, then you will only need it from 28 weeks. Women with thrombophilias who have had blood clots in the past. So we tend to divide them between heritable and acquired. So women with heritable thrombophilias, they will need it antenatally throughout their pregnancy and 6 weeks postnatally. If they have antithrombin deficiency, which is one of the highest risk thrombophilias, you will need to liaise with hematology and offer a higher dose of thromboprophylaxis. So they talk about either a sort of from 50 to 100% treatment dose of low molecular weight heparin, depending on other risk factors, depending on what your hematologist does in your hospital. The other thing to consider here is monitoring anti-10A levels. So in the vast majority of women, these do not need to be monitored when they're on low molecular weight heparin. But in these women who have antithrombin deficiency and previous clots, you may want to consider it, obviously liaising with hematology, because they will be the ones who drive this. Women with acquired thrombophilias, things like APLS and previous VTs, again, you offer 50 to 100% treatment dose of low molecular weight heparin throughout their pregnancy and 6 weeks postnatally. If they have recurrent VTs but no thrombophilias, again, liaise with hematology. They will be the ones who will sort of tell you when to start thromboprophylaxis and how much. They may, again, require a higher dose than prophylactic dose, up to 100% of treatment dose, and they will need to start it as soon as they get pregnant. This, again, brings us back to how important it is to speak to this woman before they're pregnant, as soon as we meet them, essentially. In people with asymptomatic thrombophilia, so these are people who we know they have thrombophilias, but they haven't had blood clots. Again, important to liaise with their hematologists. People with antithrombin and protein C and S deficiency, you may want to consider low molecular weight heparin throughout their pregnancy and for 6 weeks postpartum. Factor V Leiden and prothrombin gene mutation and APLS are considered as one of the risk factors. So you put them together with their other risk factors, and if they come more than 2, you start them on low molecular weight heparin from 28 weeks. You may want to consider testing for thrombophilias if they have a family history of blood clots in pregnancy or unprovoked blood clots. And the testing can be done in pregnancy if they're not on low molecular weight heparin. So just to conclude on sort of us talking about risk factors, I have 2 case studies. So the first one is these are 2 patients who I saw in antenatal clinic recently, so they're not, I haven't made them up, but it's sort of common things that happen. 45-year-old, normal BMI of 25, first pregnancy was an IVF pregnancy, and she had a provoked VTE. So she had some sort of lung surgery 10 years ago, and after that she had a PE. How would you counsel her? So just think about her risk factors and think about, would you want to start her on low molecular weight heparin? When would you want to start it? So we know that she's 45. That puts her at a higher risk. The IVF pregnancy puts her at a higher risk. And the fact that she's had a clot. Yes, it was a provoked clot, but combined with the other 2 risks, what I said to her, I said to her, I think we should start you on low molecular weight heparin from 28 weeks. She came back to me saying, I don't want to. I don't believe in thromboprophylaxis. I don't think I'm at higher risk. I go to the gym every day. I don't think my risk is higher. And this is when, it's challenging. Yes, she is active, but her risk factors are still there: her IVF, her age, and her blood clot. This is when I started speaking about the Embrace report and said to her, I understand it's horrible to have injections every day, but we know that blood clots are still one of the highest risk of death in pregnant women. But obviously then the choice is hers, but it's really important that we counsel them properly, and they know what their risks are. The other lady who I saw was a 26-year-old lady, so young girl, but she had a BMI of 39, and she was para 4 with no past medical history. Again, I put it here because I found this a bit challenging, because a BMI of 39 is just under 40. So I know that over 40 gives you more risk factor, it increases your risks. If you look at the sort of risk factor on the LCOG website, she had 39. So on paper, she only had 2 risk factors. But 39, it was probably higher when I saw her than 39. This was at booking. So I did actually discuss with her starting low molecular weight heparin at 28 weeks. But it's just to make you think. So we now move on to management of blood clots in pregnancy. So the vast majority of women go on low molecular weight heparin. Different types of low molecular weight heparin are used in different hospitals. You start as soon as you suspect a blood clot until you can rule out the diagnosis by an objective test. The dose is titrated on their booking weight, and you can give either once daily or twice daily divided dose. There's not much evidence on which one is better in pregnancy. I tend to give twice daily when they're closer to delivery, so that we'll talk about sort of what to do around delivery afterwards, but just so that you have given a lower dose in case they sort of go into labor really quickly and your risk of bleeding is slightly lower, and also implications with their regional anesthesia. In terms of, as we said, monitor anti-10A levels in the vast majority of women, it's not needed. You might want to consider it liaising again with hematology if they weigh less than 50 kilos or more than 90, if they have recurrent blood clots, or if they have renal impairment. How long do you continue the treatment for? Certainly for the remainder of the pregnancy and 6 weeks postpartum. If they have a blood clot at 39 weeks, you will need to continue it for longer than 6 weeks. So they need to have at least 3 months of treatment. But again, please liaise with your hematology team. In terms of other anticoagulants, vitamin K agonists such as warfarin are teratogenic, so we don't tend to use them in pregnancy. Very, very few women who are on warfarin antenatally, people with metal heart valves, may consider continuing them, but this is liaising with the maternal medicine team and hematology. So the vast majority of women do not go on warfarin in pregnancy, but it can be used breastfeeding. We wait until 5 days postnatally before we start warfarin, and they can continue to breastfeed on warfarin. Some women are given fondaparinux. I had a woman recently who was allergic to any type of low molecular weight heparin. She had to be given fondaparinux. Again, liaise with your pharmacists and your hematology team, considering sort of doses and how long to continue it for. Other therapies, in terms of DVTs, you may want to consider elevating the leg. TET stockings are advised in pregnancy in women who have had DVTs and early mobilization. IVC filter, it's not going to be our decision, but in people, they do consider it in people with iliac vein DVT and people with recurrent VTs despite anticoagulation to prevent them from having PEs, essentially. Around delivery. So if they have a blood clot at term, you may want to consider giving them heparin, unfractionated heparin. This is because it can be stopped really quickly and it has a really short half-life. However, it's really hard to dose it. It's really hard to monitor how well it's working. So it's not done very often. If they're on prophylactic or maintenance therapy, you tell the woman to stop injecting as soon as they think they're in labor. So when the contractions start, if they break their waters, or if they have any bleeding. If you're planning an elective delivery, so if they have a planned cesarean section booked or a planned induction, you stop anticoagulation 24 hours prior to planned delivery. Now, I've put this here, but in women with very high risks, in women with, say, antithrombin, thrombophilias, or people with recurrent VTs, you might want to consider stopping later, or even admitting them, giving them unfractionated heparin prior to their delivery. In terms of implications with regional anesthetic, after therapeutic dose, you have to wait 24 hours before you can give a spinal or an epidural. After prophylactic dose, you need to wait 12 hours. And before you take the epidural catheter out or you give a spinal, so you need to wait 4 hours before giving low molecular weight heparin after removal of epidural catheter or spinal. So just one slide on people with massive life-threatening PEs. Obviously, in these cases, it's going to be managed by the anaesthetic team. It's going to be managed by the medical team. Really important to manage them on an individual basis. The vast majority of pregnant women are started straight away on unfractionated heparin. You can consider thrombolysis in pregnancy. They may want to consider a thoracotomy or a surgical embolectomy. This will be done by the vascular team. And really important to arrange an urgent echo and a CTPA for prompt diagnosis. So just a few other important points. This talk was mainly on risk factors and management of VTs. So the purpose of this talk is not to talk about diagnosis, but just a little bit on diagnosis, because I just find sometimes it's quite challenging to diagnose a PE. First of all, radiological investigations in pregnancy tend to be challenging. The vast majority of the time, not because of the maternity team, but because you sort of book a woman for chest X-ray, they go to radiology, and I've had lots of women coming back. I haven't had my chest X-ray because the radiographer said that I'm pregnant and it's going to have risks to my baby. You can see here in the sort of pink box how low the risk is with a chest X-ray or even with a CT. The risk of radiation is really low. The threshold for fetal damage is 50. With a chest X-ray, it's just super, super low. So please empower your women and educate them, telling them this, you can show them this and tell them the risk with the investigation that you're having is really low. We are trying to educate the whole team, but sometimes it just so happens that there's people who don't know about this, and the women are scared and they don't want to harm the baby, and they'd rather not have a chest X-ray and harm their baby. So please reassure your women that the level of radiation with X-rays or CTs is really, really low. In terms of how to diagnose it, we do not use D-dimers in pregnancy. Sometimes they are requested in A&E. But we tend not to even look at the result because it doesn't tend to be, useful. And CTPAs versus VQs, very similar in terms of how well they can diagnose a PE. If the chest X-ray is abnormal, you tend to use a CTPA, but either of them can be used in pregnancy. Just references, so I mainly have the Embrace report and the 2 guidelines. It's 37A and 37B if you want to find them on the RCOG website and go into a little bit more detail. And I think this is my last slide, so I'm happy to have any questions.
Great. Thanks so much for that, Carlotta. Really appreciate that, and you stepping in at the last minute and delivering such an excellent presentation. So we've got a few questions, and we've got a little bit of time for that, which is a wonderful luxury. So from Chardin, women who have 2 risk factors postpartum, the guidance recommend 10 days to 6 weeks. At what point would you consider low weight molecular heparin for 6 weeks?
Difficult to say. I guess it depends on the risk factors, on what type of risk factors. It depends on will the woman continue it for 6 weeks? We did a survey not that long ago, and the number of women who continue thromboprophylaxis for 6 weeks, you'd be surprised, but it's really, really low. So yeah, I mean, I think it depends on the type of risk factors and your discussion with the woman.
Yeah, so an individualized assessment.
Yeah.
And the next question from Kat is, do you use or are there any plans to introduce the adapted years criteria, which I guess has been validated for pregnancy or requires a bit more research, but has certainly shown effective criteria for assessment of VTE in pregnancy to avoid unnecessary.
We don't use it yet, but as Kat said, it just hopefully we will be able to introduce it soon. It's really useful in non-pregnant women, so hopefully we can start using it soon.
Yeah, so just a bit more information around that. When you're not pregnant, there are risk assessment tools that you can use for suspicion of VTE, isn't there? But there wasn't until recent years a validated tool for pregnancy, and it appears that years, YEARS, is an assessment tool that can be used for pregnancy and suspicion of VTE. Is that right?
Yes, I think it needs to a little bit more sort of
more research,
but
but we're heading in the right direction. Fantastic. Next question. Also, do you recalculate VTE when BMI is updated during pregnancy and in the postnatal period? Adjust dose if applicable or commence if indicated?
Yeah, I think if there's a huge change in BMI, I think it's worth readjusting and recalculating VTE risk.
Okay.
I don't know what you think, but I tend to do that
Yes. I think having worked in several trusts, it's more common now for women to be reweighed, etc., and reassessed. And another question for the end of the session before I forget. So elective section without any other risk factors, does it require VTE prophylaxis? So it's one.
It's one of the risk factors. If you look at the postnatal one, I'm just looking at it now. So yeah, it's there. So elective section with no other risk factors, I'd probably consider 10 days.
Yeah. And then another question from Michelle Wright, who I work with at Ashford and St Peters. Hi, Michelle. I think you may have answered this already, but about the question around reweighing women, just in case they gain.
Yeah. So the question before, I think, was on sort of risk factors, and this one is about dosing low molecular weight heparin. It does. The guidelines do say specifically you base it on booking weight. But like, if I can see the question here, she says if she gains 3 to 4 stone in pregnancy, obviously that's a huge change in weight. So yes, I definitely consider using that weight as opposed to the booking weight.
Yeah, thanks. The next question, should we be performing a VT risk assessment at every contact or just outpatient contacts,
Every
i.e.
contact.
triage? Yeah.
Yeah, because things can change, and yeah. And I think when we see women in an outpatient setting, they're more likely to sort of just, yeah, tell us about different changing situations and things.
Yeah. And I'll just take up Jadisola's, hi Jade, her question around transferring. So would you take the booking weight or would you reweigh and dose according to the new booking weight? I think that relates to Michelle's question around
so
would you
I would
reweigh?
probably use the new one. Yeah, I think so.
Yeah, yeah. Any consideration, a correlation with low weight molecular heparin and low platelets, and how do you balance those risks?
Yes, so starting women on low molecular weight heparin, so it's one of the risks is that they get low platelets, and liaise with hematology. We had a recent case of a woman with very low platelets who needed low molecular weight heparin because of her other risk factors. So really important to liaise with hematology, and it's a risk, it's a balance of risks and benefits, essentially.
Yeah. Great. And can you see the last question there, Carlotta? But the so the elective section risk only being scoring
I agree.
one. Yeah.
I agree with what she said. In theory, so the elective section is only one risk factor, but I'd feel uneasy not to prescribe low molecular weight heparin. I completely agree. Me too.
Yeah. Okay, fantastic. Okay, we've got, I think that's all of our questions answered. So thanks so much, Carlotta. Lovely to see you in person.
Thank you for having me.
And yeah, thanks again for stepping in at the last minute.
No problem. No problem.
Okay,
Thank you.
thanks. Bye.